Dr. Frank Rimell, who really needs no introduction in this crowd. Probably most of you have interacted with Frank at one time or another. He's a longtime ENT doc here at both the University of Minnesota and at Children's Minnesota. And I'm sad to say that he's moving on to the next step of his career to Cedars-Sinai, where he'll actually be starting an entirely new ENT program there. So sad to see him go, but wanted to have one last time to hear Frank speak. And Frank's going to be talking about a new way to place otolaryngology tubes. Frank, thank you very much.
Thanks, Glenn. Thanks for having me, everybody. For those, I'm going to go a little bit of history and reminisce a little bit just for fun. When I first came here 25 years ago, there was no Peds ENT, and I had a task of dealing with children in town and me coming to the university and a lot of the relationship issues that you guys are still today that goes on between children's and the U. And I love the U because I did my residency here. There were great researchers here. I was into research at the time. But I always thought otitis media was stupid. I'm like, simple problem, put tubes in, they're done. And I keep coming back to the simple issue of otitis media and dealing with it, obviously the most common problem we all see. And fortunately, over time, I was able to get ENT to be a combined program between, as you guys know, ENT is probably one of the few, if only, combined programs between Children's and the university. It works well, it functions well. We're all combined staff. There's 8 pediatric ENT docs, and we share everything, fellowship, residence, between Children's and the U. So, and I helped, when I came, I started the Lions Children's Ear and Hearing Clinic. I did the first cochlear implants in the United States in kids, so I have a long ear history. And I keep thinking there's bigger problems in otitis media, but I keep coming back to otitis media. So that's kind of what I'm going to talk about today. I need to declare, I'm going to talk about some off-label issues, and I'm going to bring that up and point it out when I do it. And I have to declare that I'm Chief Medical Officer of Preceptus Medical, which we're going to talk about. I'll point that out so that you guys are aware of my conflict of interest. This is not the first company. The advantage of being in Minnesota is there's a lot of companies here, and as someone who does research, or I've always liked tinkering and developing devices. There's a lot of opportunity in Minnesota to hook up with companies and develop things that go from the lab directly to patient use. The traditional translational idea, and that's the beauty of being in Minnesota. So I've had opportunities to work with several companies, hopefully in an ethical way that's always approved by the UMNPeds and by Children's, so to help better things. And so, but I'm going to want to talk a little bit about just otitis media issues in general nowadays anyway. And Dr. Ferrari can correct me because she's one of those experts from a long time, on this topic. I want to bring up our dear old friend Scott Giebink, he was chairman of the department at one time. So Scott Giebink, for the younger folks here, is just an excellent example, a dear friend of mine, just one of the world's one of the world's experts on otitis media. And really, for you guys who don't know this, the University of Minnesota was one of the world's leaders in otitis media research. We had huge NIH grants here in both the Department of Pediatrics and Department of Otolaryngology. A lot of the stuff we know about pneumococcus today and otitis media came from the University of Minnesota, came from people like Pat and Scott Giebink, and those and so a lot of what we do today is based on this. Scott and I used to do a joint clinic together. It was actually a combo clinic of pediatrician and ENT doctor. We did it once a week, and we saw all the really bad kids who had terrible otitis problems that kept draining after PE tubes. They had persistent problems or had bad sinusitis. And Scott's only mistake was that he was the first board chairman at UMP. But other than that, he was just an outstanding individual and researcher, and taught me as a surgeon how to take cultures. Like, most of us ENT docs, we never take cultures. It's a draining ear, we'll just throw whatever on it. And I learned a lot about the importance of cultures, resistance patterns. It's amazing when you get out in the community what a poor job most of these hospitals do on determining resistance of the bugs they're growing and trying to get a really good, like a lot of bugs, they'll just, Haemophilus, whatever, they'll say, oh, you know, they won't even test it for resistance half the time, or even have trouble getting pneumococcus tested a lot of times. So it is nice that you guys are in a facility that does a good job in looking at the bacteria that are growing and the resistance pattern. And, you know, it's something I kind of miss sometimes now I'm out in the community about getting good micro data on the bugs I'm growing. But, you know, what a major legacy Dr. Giebink did for the university and for otitis media. And people still constantly refer to his work on otitis media, and we still use it a lot. So, and the department actually has an award named after him. Because of all the great work he did for children and pediatrics and access to care and immunology. So the OR. You know, I'm a surgeon. I like everything in the OR, but now I'm going to talk about how to get something out of the OR because I do chew a lot of gum, and this has happened to me before with the gum sticking. Do I actually blow bubbles while I'm operating? Yeah, sometimes I do, and I've had that problem. So that's part of my impetus for trying to get things out of the OR. I will argue that otitis media is probably the most difficult diagnosis to make. It's such a simple problem, and if someone's really honest with themselves, it's hard as heck to diagnose. I mean, it is. To make it accurately, I can't tell you how many times I see a child in the office, and they were at Ready Care 2 days ago. It said they had acute otitis media, and they're totally normal on exam. They have normal tympanograms. They have normal hearing. This happens all the time, and this is a real thing that whenever I have pediatric residents, family practice residents rotating with me, I tell them, look, they're all freaked out that they made the wrong diagnosis, you know, in the office when they're rotating. I'm like, this is the hardest diagnosis to make correctly. You got a kid who's moving, they got some wax in their ear, and none of us really do mobility, you know, in the office. I mean, we do as otolaryngologists, but most pediatricians and family practice physicians don't do mobility. And, you know, then you have the parents who go to CVS and get the otoscope, and they think they can diagnose otitis media in their own kid. And I try and explain to them, like, this is a near impossible diagnosis to make correctly. It's very inaccurate. And depending where you look in the literature, there's a lot of articles on this topic. And the people I've trained with, both at Children's Hospital Pittsburgh and here, you know, I've written on this topic too, that the overdiagnosis is made in the literature probably, depending whose article you read, from 25 to 40% of the time, it's overdiagnosed. I mean, a kid comes in, you know, to Ready, they always say, oh, it's an ear infection, here's an antibiotic, even though a lot of times it may not be. That's just kind of the thing. I'm going to stress the use of tympanogram because no one knows how to do pneumatic otoscopy. It's kind of a lost art. That's what I was taught how to do, and it is hard to do accurately and get a feel. You know, are you overpowering that eardrum? Are you moving it too much and giving a false sense of mobility? Or do you not have a good enough seal and there really is no fluid in it? You're just not moving because you don't have a good seal. And you know, the otoscope tips they have are so cheap nowadays and they only give you like one choice that half time they don't even fit properly. And then you got cerumen issues in there. But I'm going to really encourage for everybody to use tympanograms. They're cheap. They're portable. And I think particularly your first 5-10 years in practice, it's really helpful to get feedback. Now, the issue on tympanograms is if you get a normal tympanogram, it's going to be a normal eardrum. There's no way there's otitis media because the definition of otitis media is really there's fluid back there. So if you got fluid, it's not moving. So if you get a flat tympanogram that's low volume, then it probably goes along with either OME or AOM, depending what's going on in the history. If you get a normal tympanogram, it's normal. I mean, there's no way you got otitis media going on. Now, the problem with tympanograms is you get a lot of false positive tympanograms in the sense that it's pretty easy to get a flat tympanogram if it's not positioned right. So if you get a normal, peak normal tympanogram, you don't have otitis media. If you get a flat tympanogram, it may be otitis media, or it just may be a bad tympanogram. So again, if it's flat, you still have to use your diagnostic skills. If it's normal peak, then it's going to be a normal ear. If it's flat, then it could be a false flat or it could be real. But it does kind of help you. Again, it's part of the picture. The disadvantage that pediatrics has is they don't get good audiograms in the office. And that actually helps us otolaryngologists a lot. Because if I got normal hearing in both ears, then it's probably not otitis media. So for us, we have all this data. We have tympanograms. We have good audiograms from pediatric audiologists. It really makes us much more accurate. we're wrong too. You know, I actually went through a validating test back at Children's Hospital Pittsburgh where I would have to look at a child before the OR and predict what I saw, and then we'd go to the OR. And this validated otoscopist, which I am, but I haven't been recertified. Joking, there's no recertification for it. But the validated otoscopist, you're allowed to be wrong 10% of the time. So as an expert in otoscopy, I'm allowed to be wrong 10% of the time. I mean, that's kind of crazy. And then, you know, a good pediatrician by literature is probably wrong close to 20% of the time. And the ready care people are probably wrong half the time, to be honest with you, in an accurate diagnosis in a young child of otitis media. So for the residents, don't be embarrassed that you don't like get it or you're wrong, because it really took, and I still make mistakes, a good maybe to the end of my PEDS fellowship, so 7 years of doing residency and PEDS fellowship before I thought I was pretty good at diagnosing acute otitis media. It is super hard to make accurate. And I think the literature and the people who do research are kind of understanding this issue of accuracy of otitis media diagnosis. So I'm going to go to the key action statement here. I think most of us live by nowadays, which is clinicians may offer PE tubes for recurrent, I interchange tympanostomy tube with PE tube throughout the talk, so may offer tympanostomy tubes for recurrent acute otitis media, 3 episodes in 6 months or 4 episodes in 1 year. This is kind of the guideline that a lot of us use. But I'm going to emphasize the word may. It doesn't mean they have to have it. It really should be may. To me, it means not PE tubes, it means referral to the ENT office for a good audiogram and a discussion with the parents about what's going on in that child. Because as we all know, every human being is different. There's a lot of pictures, a lot of things that go into the picture and decision making of should you offer PE tubes or not. It should be written in terms of, and I'm friends with a lot of these people on this panel and have email discussions constantly. Actually, I just had one last night with Rich Rosenfeld, who's the big ENT doctor who's really kind of in charge of these panels. Even though, you know, I keep thinking, who cares about otitis media? But I think it should be referral to ENT. So my attitude is when you talk to parents and they've had 4 ear infections in a year, it's really it's time to see the ENT doctor, talk about PE tubes, get a good hearing test, see what's going on. And as you know, in town, there are ENT doctors that are very aggressive about doing PE tubes, and there are ENT doctors who may be a little conservative. And I think part of the challenge as a pediatrician is finding who you trust as a surgeon who's going to try and treat your child appropriately and correctly and not just slam PE tubes every time they're seen. In terms of AOM, OME, and PE tubes, ultimately, the concern is, you know, parents, they get concerned nowadays. They're pretty educated about antibiotics, most of them. So it's funny to watch from the early 90s and late 80s about every parent wanted an antibiotic every time they saw you to, you know, I'm really concerned. And I get this all the time. Parents will bring this up. Our kid's been on 6 antibiotics for otitis media. And they're tired of it, and they're concerned. They're worried about, you know, what's going to do to their immune system and those kinds of things. So parents and the press and us as physicians have done a pretty good job, I think, in the last decade of trying to say, hey, we've got a problem here with the overuse of antibiotics, and the parents are becoming more aware of it, and they're starting to understand that maybe all this antibiotic use could be a problem. So we're starting to, again, get to this balance of, in the 80s and early 90s, of forget tubes, let's just do antibiotics, to maybe swinging back a little bit to the use of tubes for drainage versus multiple antibiotic use. Now, one of the things I want to talk about so one of the concerns, obviously, is a lot of antibiotic use. And the only concern about multiple antibiotic use I really have is a patient who's getting allergic to antibiotics. Because if they're getting allergic to amoxicillin and cephalosporin, I personally start getting worried a little bit about later in life, and then maybe they are, you know, a strong reason to do PE tubes because they're getting allergic to different kinds of antibiotics. So save that for later on in life and put the tubes in. The speech and language issue, to me, is a bogus reason. Every parent's concerned about their child. Oh, my child's delayed now. I have their sister spoke at 12 months and they're 18 months not saying a word. This has been really well studied, and I actually participated in some of these studies that if a child's otherwise normal and healthy, and I'll show some articles on this, they catch up. So I always have this talk with parents about, don't worry about the speech and language delay right now. If the child's otherwise normal and healthy, by the time they start kindergarten, they're totally on track with everybody else. And we're not going to let this problem go on forever anyway. So the fact that they're 6 months behind in speech and language development is not really a good reason to PE tube placement. What is a good reason is the concern about permanent hearing loss. And that's what I try and bring parents back to and say, look, the real reason I am concerned as an otolaryngologist about the recurrent otitis media is the fact that if you look at this problem pre-1950, and by the way, tubes came around in the mid-50s and so did, penicillin. But if you look at this historically in other underdeveloped countries, the real problem with all these ear infections, you get permanent hearing damage. You get permanent damage to the ossicles, to the tympanic membrane. You end up with permanent hearing loss in one or both ears, which can affect you the rest of your life. So that's really the reason why we want to treat this with antibiotics or tubes and prevent it. The other big reason was pneumococcal meningitis, which when I started my training was a major, major issue. Obviously, most forms of meningitis in kids were due to pneumococcus, and the thought was it's mostly from ear infections. And this is where the University of Minnesota was a real leader on research and understanding this and understanding pneumococcus and the relationship. So the antibiotic use really started more in this country. Some of it was medical legal. There's a lot of history behind it. The people I worked with in Pittsburgh, there was some issues about, their money given to them for research on pneumococcus and amoxicillin. But really, a lot of us was giving it because we didn't have the pneumococcal vaccine. And if we saw a child who came in the office with otitis media and we didn't treat him, and then that child got meningitis, we were toast medical legally in our system. So it almost forced us every time we saw a child with otitis media to give them an antibiotic to prevent pneumococcal meningitis. This is probably changing as a reason to do antibiotics for otitis media as the vaccine gets better and better and better. But there was no vaccine when I started, and that's why we gave tons of antibiotics, which really, not only, helps pain and fever for a day, but really you're doing it to prevent that. So this is one of those, this is a famous Paradise study in New England Journal 2003 that I participated in and helped on when I was at Pittsburgh, where we looked at large groups of children who had otitis media and then followed them later on in life. And really, their speech and language goes back to normal. So again, this idea of parents upset about the speech and language delay, and otherwise, this is not including kids with Down syndrome or other neurologic issues, but if they're otherwise totally healthy, speech and language delay is temporary. I always tell parents, look, don't worry about it for that. They'll catch up. We're not going to let this go on forever anyway. So I kind of try and dismiss that as a reason to take someone to the OR and do PE tubes. There's another study again by Rich Rosenfeld, again looking at otitis media, speech and language. It's a meta-analysis of a lot of studies, and basically they all say the same thing. Speech and language is not a major reason to put PE tubes in kids. So, like I said, they'll catch up. The real issue, again, is the issue of permanent hearing loss. And there's a lot of studies to support that. The kids who have a lot of problems with otitis media tend to have problems with permanent hearing loss. So that's really, when I talk to parents about, well, you've had a lot of ear infections, the real reason to put your child under anesthesia and to get PE tubes is because you're trying to prevent the permanent damage done by the otitis media. That's what you're looking at. And in the past it was pneumococcal meningitis. That's kind of gone away. Speech and language delay is not a reason. It's really to prevent the permanent damage from multiple episodes. That's why we're treating it and we're putting PE tubes in. The vaccination, maybe I remember when if you look at the history of ENT, it's kind of funny. When penicillin came on board in the 50s, they said that was the end of the ENT specialty. Like, there's no need for ENT doctors. We got penicillin. And as time went on, actually the opposite happened. And again, they're saying the same thing, pneumococcal vaccination, as it gets better, there'll be no more otitis media, no more need for P tubes. There's definitely a reduction in the events of otitis media and PE tube placement. Is it going to totally stop it? There's other organisms that cause otitis media besides pneumococcus. Maybe they'll become more prevalent. You know, vaccinations are a wonderful thing, obviously. It eliminated a lot of terrible problems. We used to see this disease called epiglottitis, which was caused by typable Haemophilus influenza. And when you were a resident ENT doctor, that was the scariest thing you could run into was epiglottitis, where they get this typable Haemophilus influenza. It swells and it scares the bejeebers out of anyone. You go to the OR and everyone's just kind of on edge because the kid's barely breathing and anesthesia's nervous and we're nervous. You know, can we get a tube in? Do we have to do a slash trach? And vaccinations eliminated it. You know, typable Haemophilus influenza got rid of it. Is it going to happen with otitis media? I hope so. You know, will it? It's hard to say. It's definitely making a knock and a dent as the vaccine for pneumococcal gets better and better. We are seeing a reduction in the number of cases and PE tube placement. So it is a wonderful thing. You know, it'll be interesting to see over history, you know, as things happen, you know, will it continue to decrease? Surgery for children, less than 4. Clinicians should recommend tympanogram tubes when surgery is performed for OME in a child less than 4 years of age. So I'm going to talk about this adenoid issue. Most of the episodes of otitis media are strongly related to the adenoid. The adenoid, not tonsil, just adenoid. And this has been studied numerous times. If you take, most of these studies are kids 3 and 4 years of age, not under 3, and probably not, and nowadays really not under 4. The adenoid, we view it as a cesspool effect. You know, it's full of the bacteria, and somehow it's getting up the eustachian tube. A lot of us think it's a negative pressure effect, where it's almost like the middle ear space is sucking the pneumococcus from the adenoid up into the middle ear space. And when you put a tube in the ear, you're actually equalizing the pressure, so you're not pulling pneumococcus or Haemophilus or whatever out of the nasopharynx into the middle ear space. That's how we think a PE tube works. You're cutting a hole, you're letting air flow in, you're equalizing pressure behind the eardrum, so you're not pulling bacteria out of the nasopharynx up into the middle ear space. If you take 2,000 kids the same age, let's say the age of 4, and they're on their, this is the classic study. So there's 2,000 kids around the age of 4, 1,000 of them are on 2,000 kids around the age of 4, they all need their second set of PE tubes. So 1,000 of them get an adenoid with their second set of PE tubes, 1,000 just get a second set of PE tubes. And you follow those kids out. The ones who get an adenoid with a second set of PE tubes, there's a huge statistical reduction in the need for a third set of PE tubes. So adenoid clearly makes a difference in an older child, i.e. 4 and above. We used to think it was 3 and above in terms of further otitis media problems, statistically. A lot of us, when these studies first came out, felt it made a difference in kids that were 1 or 2, that if you get rid of the adenoid, if they're 2, let's say they're 18 months of age, they're getting first set of PE tubes. A lot of us thought, well, if we do their adenoid at the same time, let's say they have some nasal congestion at the same time you're doing their first set of PE tubes at a year of age or 18 months. If we got rid of the adenoid, maybe it would prevent a second set. That turns out probably not to be true. And a lot of it is, if you understand these patients, if I take out an adenoid when they're 18 months, it grows back so quickly. There is no surgical plane for an adenoid, unlike a tonsil. When we take out a tonsil, there's a surgical plane. We can get rid of all that lymphatic tissue. When you take out an adenoid, it's stuck towards to the ligaments on the spine. You can't get all the adenoid out. Otherwise, you're down on the spinal cord, or the fascia over the spine. So you're always leaving a little adenoid tissue in the nasopharynx. We're basically just debulking an adenoid because there is no surgical plane to sweep the whole thing out. So it always grows back until it starts to not grow anymore when they're 10, 12, 15. You know, when you're 10, 12, 15, your adenoid kind of shrivels up and goes away. Adults don't have adenoid tissue for the most part. So this idea, so even 5, 6 years ago, I thought, well, I'm going to take out adenoid. They're 1 year of age. They have a runny nose all the time. I'll help prevent a second set of tubes. That's being shown to be totally false. So adenoids really aren't effective till they're older, 4 years of age, because they're less likely to grow back and be active. If they're 2, 1, you take them out, they're going to grow back in about 6 months. And I've started to warn parents now that if I'm going to do their adenoid, it's going to grow back. Just be prepared. Don't be mad at me, because I used to get mad they come back and the kid was stuffy again in the nose because it grew back right away. So we're starting to find out that, you know, as a pediatrician, and let's say the parent comes back to you to talk about an adenoid, it's not really that effective when they're under 4. I mean, we'll still do it sometimes, but it's truly not that effective. When they're over 4, then it seems to be effective. So we'll use it for OME problems or recurrent AOM, you know, or then doing an adenoid really probably helps prevent recurrent problems with otitis media. So yeah, again, for children greater than 4, the data is pretty strong on this, and the research is pretty strong. You know, you should start thinking about an adenoid with a PE tube, or an adenoid for OME for PE tube. So an adenoid for either, for either recurrent acute otitis media or for chronic effusion OME. Now, the other thing I want to bring up is, to this point, there's no way for us to do an adenoidectomy without general anesthesia. So, which actually kind of plays into this hand about, is there a way to avoid general anesthesia in kids, particularly under 3, which I'm going to talk about that whole topic here in a minute. So, if a child needs an adenoidectomy for PE tube placement, they're going to be older than 3 anyway for it to be effective. They're probably going to be closer to 4. And I'm going to get into this target of avoiding the OR for kids under 4 and the whole FDA issue, which I'm intimately involved with and have been at the FDA and have had arguments with the FDA about this topic. All right, so I'm going to sidestep a little bit, and I'm going to make, are there any anesthesiologists in the audience? I hope not. Because I've had, obviously, this whole idea of getting kids out of the OR for the #1 procedure in the United States. I'm not very popular amongst anesthesiologists. They have come after me full bear, locally and nationally. So, so there's no anesthesiology. I don't have a bulletproof vest on, so I think I might be okay. So it's kind of funny, you know, about anesthesiologists. The AHRQ put out this thing about, as using nitrous for delivery is becoming more popular. You know, a lot of European countries and Canada use nitrous for labor as a way for mothers to help them out. And the government, the U.S. government, the AHRQ, CMS put out this, we want to know position statements on this use of nitrous for labor and delivery. And of course, our friends in anesthesia and the Committee for the American Society of Anesthesiologists wrote, hey, you know, nitrous is dangerous for children under the age of 3 and it shouldn't be used. And the reason they're against it is because nitrous is the only thing that anybody can use. It's not hard. I'm licensed to give nitrous. Like, anybody can give nitrous. Any nurse can take a course and give nitrous the next day. I mean, you know, as you know, you go to the dentist, and any dental office, they're giving nitrous, dental assistants giving nitrous. There's no control over the use of nitrous oxide. I think medical legally, you go take your course, it takes 3 hours, and you can give nitrous oxide. Because it's hard to hurt somebody with nitrous. I mean, you can, but it's pretty hard to do nowadays with the delivery devices. So, of course, anesthesiologists have no control over nitrous oxide, because a nurse can give nitrous oxide. You don't have to have a physician to give nitrous oxide. So they wrote this idea. They started making a big deal to the AHRQ about the use of nitrous in children, that, you know, it'll hurt their neural development if you give a pregnant mother or a mother who's delivering nitrous oxide. I think the government, or AHRQ, kind of saw through that. It's becoming more popular to use. They put in their statement, recent work has demonstrated the neurotoxic effects of anesthetic agents on rodents and primates, and so they were really concerned about it. However, once the FDA comes out and talks about it, now anesthesia is very quiet about it, and they don't want to talk about it. And this has been the ongoing argument, and obviously this is the big controversial statement that I'm sure a lot of you are running up against. And what do you do now? The FDA is kind of black boxing anesthetic agents in children under the age of 3. The U.S. Food and Drug Administration is warning that repeated and lengthy use of, I got a laser pointer here, huh? Oh yeah. Of general anesthetics, sedation drugs during surgery or procedure in children younger than 3 years of age or in pregnant women during their 3rd trimester may affect the development of children's brains. Consistent with animal studies, recent human studies suggest that a single, relatively short exposure is probably not an issue and unlikely to have negative effects on behavior or learning. However, further research is needed to fully characterize this effect. And again, they're talking about a single exposure. So the FDA came out, and I'm sure everyone's aware of the issue of general anesthesia in children under the age of 3. Is that right? You know, show our hands, or, yeah, okay. And now everyone's quiet about it. Like, anesthesiologists really don't talk to their patients about it. My colleagues don't really talk to their patients about it. It's even though it's out there, none of us really talk about it to them because we're afraid it's going to scare them, and we don't know what's going on really. And again, the recent data seems to show that one short exposure under the age of 3 is probably not an issue. So PE tubes take 5 minutes, so one short exposure is probably not a big deal at this point. I think they're starting to get concerned about exposure for 3 hours. And again, unscientifically, I look back and I see my patients have had multiple surgeries and see them 10 years later. I mean, you do kind of wonder, was it the fact that they had a problem and needed 5 surgeries, or was all the drugs we were using really affecting their neural development? It's most of the studies are animal studies, and that's always the dilemma we're dealing with, and we don't know, does the human brain react the same way as a primate brain or a rat brain? The issue is, and what people seem to forget about in the arguments, when I started going after this idea of we got to do something about PE tubes, it's the number 1 procedure in the United States. All these kids are getting exposed to anesthesia. Maybe I'm concerned. If it was my kid, do I really want him exposed to anesthesia for PE tubes? And the anesthesiologists are all arguing me, it's one short exposure, blah, blah, blah. It's not a big deal. People forget that 30% of kids get a second set of PE tubes before the age of 3. And there is strong data showing that multiple exposures to anesthesia are just as much of a problem as one long exposure. So, the classics, the Mayo study done right here in southern Minnesota on those kids a lot of those patients included kids who got multiple PE tubes in their study groups. And that the kids who got multiple exposures to general anesthesia were developmentally behind and from a learning perspective behind their peers who got no exposure to general anesthesia or one exposure, that there was a big effect from multiple exposures. And so even though now that we've kind of comfortable saying, one short exposure in a child under 3 is probably not a big deal, we have no clue about multiple exposures. And 1/3 of kids get 2 sets of PE tubes before the age of 3. That's been shown in multiple studies. I use O'Neill's study because she happened to be one of our fellows in our fellowship. But there are a lot of studies to show 1/3 of kids roughly, that's the statistics I quote parents, about 1/3 of kids get a second set of PE tubes. And that second set's going to be under general because it's going to have an adenoid. So the question is, can we avoid that first exposure? And an adenoid is short too. So an adenoid in PE tubes, 15 minutes. The question is, could we avoid that first set? And until we understand the risks better about multiple exposures to children under the age of 3, can we totally avoid anesthesia totally on that first set? That's kind of where we're going after. And this is the FDA, these are the FDA agents, and obviously SIBO is what everyone uses for PE tubes nowadays. So, and this is what they get exposed to. Also, what I didn't show on this list, but Versed is another concern agent. It's these groups called the NDMA drugs. Now, interestingly enough, nitrous oxide, and I'm going to keep swinging back to nitrous oxide. So laughing gas is also that same family, NDMA. And so the argument, when we started saying, well, let's do tubes under nitrous, could we do tubes under just laughing gas instead of SIBO? Everyone's arguing, and including the FDA at the time when we were up there, they're all saying, well, nitrous is the same family, what are you saving by that? Well, if you really look at the literature carefully on animal studies in nitrous, the ones that showed a problem in neural development animals all had other drugs given. They were given with some of these other agents, ketamine, whatever, at the same time. And that the few really pure nitrous studies really didn't show an effect on an animal brain. And I believe personally it has to do with the way nitrous oxide works. Nitrous oxide is the only agent of that family, the NMDA, that's not metabolized centrally. All these other agents are actually metabolized centrally. So as they get through the blood-brain barrier and do their things, the neural tissue actually metabolizes those agents. Nitrous oxide is not metabolized by neurons. That's, to me, the big difference in why nitrous oxide seems to truly be maybe a safer agent. But again, that's all up for further studies. That's all conjecture on my end. So what does the AAP say about this? Well, they say the honest thing, that pediatricians and, to be honest with you, surgeons should have an open, still not used to your thing here, should have an open and seasoned discussion with parents about procedures, including imaging studies that need general anesthesia that require these things. But does really anybody talk to parents about this? I am not seeing it. And it's a really huge kind of dilemma that is going on out there. So regional anesthesia may be an alternative for some procedures. And this gets the idea of, can we stop, it's like radiation, can we avoid, can we use ultrasound? Ultrasound, as an ENT doctor, ultrasound sucks. I mean, it's wrong most of the time. There's nothing like a CT. But I know the ER docs are laughing. It does suck. You know that. Every time you guys call us, I'm like, ultrasound's totally worthless. But, it will get better. But we want to avoid radiation in kids. We need to, maybe until we understand this better, avoid general anesthetic agents if we can, particularly multiple exposures. But no one really talked to them. Most of us nowadays are talking to our parents about radiation. We're not really talking to them about general anesthesia. And probably we should, if you want a truly informed parent. But I don't think any of us really know how to broach this subject. So why do we need general anesthesia for PE tubes? It hurts like hell. It really does. Even the act, you guys have tried to clean cerumen out in a year in the office. These kids, they cry, they're all over the place. It hurts. None of us want to do it. And I can't tell you how many times we've had a kid under general anesthesia, and the minute you start to make the laryngotomy, they move like crazy because it requires a huge MAC, a huge concentration of anesthetic for them not to feel it. The eardrum and the ear canal is exquisitely sensitive to pain. And this is the whole reason of us developing local anesthetic for PE tubes. There really isn't a good local anesthetic for PE tubes unless you physically inject the canal with lidocaine, epinephrine. But when you do that, you risk some of that lidocaine getting into the middle ear space and causing 6 hours of nausea and vomiting and a caloric effect in the middle ear, which is why most of us don't do it. Plus, it hurts when you inject like crazy. And then if you get the lidocaine behind the middle ear space, sometimes you're admitting those kids for a whole day because they're throwing up because the lidocaine got to the vestibular system and causes them to be nauseated. We do not have a good way to numb the eardrum in 2018. That putting EMLA on there doesn't work. It's amazing how sensitive that part of the body is. So we need a cooperative patient for PE tube. There is a local we use that's called phenol, and basically phenol is really a caustic agent. When we put phenol, we have a little applicator. We'll take a little Q-tip and we'll put phenol in the spot we're doing our laryngotomy, but it burns and stings like crazy when we first use it. And all phenol is doing is it's killing the nerve endings on the eardrum. That's how we do our local anesthetic. That's the only effective way. We'll put a chemical to kill the nerve endings in the spot we're doing the laryngotomy. That's how most of us do it. But you have an older kid who's 12, you have an adult, and you say, hey, this is going to sting for a second, hold still. They will. And they'll hold still, and then you put the tube in. That obviously a 2-year-old or 1-year-old is not going to do that. So basically, requires a cooperative patient, wax is removed, a knife through the eardrum, any fluids removed, and the tube's put in. And by the way, this is another, I don't want to go over here, this is another important step, and that is, do you really need, this is something that we've brought up and I've written on, is do you really need to remove the fluid in the middle ear space when you put a tube in? The answer is probably not. And ENTs are fooling themselves if they think they're really getting all the fluid out. So when you put a tube in and a gush of fluid comes up, a lot of ENT doctors think it's important to suction the fluid. And by the way, that's another reason for anesthesia, because how many kids are going to hold still when you get a sucker on the eardrum, you're sucking fluid out, and the noise is like 90 decibels. The point is, there's really fluid. If you've ever CT scanned a kid with otitis media, there's not only fluid behind the eardrum, there's fluid in the whole mastoid complex. And I'll get a call from a doc saying, oh, the kid's got mastoiditis because they did a CT of his temporal bone. But whenever you have otitis media, it's all through the mastoid. It's behind the eardrums and the mastoid. When you suck fluid out, you're not sucking all the fluid out from the mastoid. What's happening is the tube and equalization of pressure is going to clear that fluid out over several days. So when I talk to my colleagues, I'm like, and they say, well, I like to suck the fluid out. It helps the child. It's like, you're not sucking all the fluid out in the antrum of the mastoid. That's still there when you suck the middle ear fluid. It's got to come out on its own over time. So we've shown that if you take a child and you don't suction their fluid at the time you put tube, and you follow that kid and test their hearing 3 weeks later, they're fine. And the tube's fine. You don't have to suck the fluid out, and you're not getting it all out anyway. So, and understanding that actually helps us design maybe a procedure where that's going to be more comfortable for a kid if we're going to get away from general anesthesia. That's why I bring it up. So it's actually more like 1.4 million a year. It's the most common operation in the United States. It's the most common reason why children are exposed to the drugs of anesthesia under the age of 3. We've been doing it the same way since the 1950s. Can we do this differently? So what happens nowadays when a kid gets sent to us for PE tube placement from pediatrician. It's crazy if you guys have had to do this with your kids. So they've seen the pediatrician like 8 zillion times. So, I've seen the pediatrician 4 or 5 times, had lots of antibiotics. It's time to see the ENT. They come and see us, and we see them, we get the hearing test, say, yeah, you need PE tubes. Now you got to go back to your pediatrician, get the pre-op H&P, then you got to come back to the procedure place another day, and your kid's got to be NPO for, 8 or 12 hours in a scary place for something that takes 5 to 10 minutes. Then you got the whole cost issue, forgetting all the safety issues. It's huge cost. You got an OR facility, you got anesthesiologists, you got pre-op nurses, post-op nurses, recovery room. The estimated cost is around $4 or $5 grand per procedure. Maybe more or less than that, but it's kind of a rough estimate. But it's also what no one counts is the inconvenience and cost of the parents who's taking multiple days off work to go back and forth between the ENT, the pre-op, etc. So, can we get tubes out of the OR and just do them in the office? And so there are actually 3 companies in the world working on this right now, just of interest. So, the people are starting to understand that maybe this is the next wave. There's a wave in surgery in general, getting things into the office out of the OR for all procedures. And it's kind of what I'm seeing in surgeries is, particularly in adults, because if you give adult a choice, do you want a local or do you want general? Most normal adults are going to say, I'll take the local regional, I want general. Why is that okay for adults but not okay for kids? Why can't parents decide for their kids, I don't want general, I want local regional like I would for myself if I was going to get my elbow fixed, But there's a counter argument to it. So the device has been developed, and I actually have worked with 2 different companies on this, on getting a tube placement. So this is kind of my conflict of interest. I'm chief medical officer of this company. This is one way to put PE tube in. And the purpose of it is to do a single stroke. Instead of making a knife cut and putting it in by hand, and the kid's wiggling, can we just get close to the eardrum and pop a tube in real quick and be done and more accurate? So that's kind of the part of this where we're getting a device to develop it. So we developed a protocol initially where instead of doing the office, we're going to take the baby step and use nitrous oxide. Remember, nitrous oxide is not general. They just don't know what's going on. They have amnesia. They have some analgesia from it, but they're not general. So the kids are moving around. So we started with, we went to fentanyl because we didn't like Versed because Versed was a drug of issue in terms of possibly causing neural development. So we went with intranasal fentanyl, and then we gave them nitrous oxide. We put phenol and put the tube in. And we had a backup for propofol if it didn't work. So we didn't have to take kid to the OR. This is actually me, and I like this because I don't have to wear scrubs. I can wear a nice shirt and tie and put PE tubes in. And this is in a sedation unit, and under the microscope, and we're just putting PE tubes in, pretty simply without general anesthesia, and I'm in street clothes. As opposed to the OR, where you're under general. What we found is the average PE tube procedure took 11 minutes in sedation, but the big thing is they only stayed in the hospital about an hour, as opposed to when you do an OR tube, they're in the hospital about 3 to 4 hours between pre-op, post-op. So there is a cost savings from that. We tried one without fentanyl. It didn't work as well, so we stuck with our fentanyl. And none of them were converted to deep. They all worked. So at least the ones in the sedation unit. Now, I'm going to take a step backwards. And the parents loved it, of course. It's your typical parent study, but that's pretty common. We actually started in the OR first. We did this, and we published our findings in the OR. It was a combo between Mayo and us. We did this study, and we put it in the operating room. And what we found, it was fascinating, culture. We had a pretty decent failure rate in the OR where we had to convert to general. And I think it's on the next. Dave Beebe, who's an anesthesiologist here, participated in it. Chandra Castro, Kumar Balani, you guys probably all know. We're all part of the study. My battery died here. Well, let's go. I'm jammed here on my slides. Probably doesn't want me to talk anymore. Oh, there we go. Sorry. We had 11% failure, 12% failure rate in the OR with the same protocol that we were 100% successful in the sedation unit. And that gets the culture in children. The OR, first of all, coming into this, everyone was against us doing it. It's their jobs. The anesthesiologist was against it. The nurses in the OR were against it. for some reason it seems to be perfectly acceptable to hold a child down to put him asleep. So if you're inducing anesthesia, they're fighting you, you can hold them down. But it's not okay to hold a child down when you're putting their tube in because they're moving around. And so they freaked out because they were moving when we were putting their PE tube in. And there was a lot of failures where I just said, just convert them to general because everyone's freaking out. But if you get to a place that's used to dealing with children under sedation, you'll have a 100% success rate. So we got out of the OR, 100% success rate in the sedation unit. The problem is most places don't. You guys are blessed with a good pediatric sedation unit here. Children's is blessed with a good pediatric sedation unit. In fact, sedation unit here at Masonic is outstanding, and we started here. So, but most places don't have that blessing of a great sedation unit. So again, a lot of the issues is culture in children and where you're doing the procedure. So, and a lot of people don't understand that we hold kids down in the office to get foreign bodies out of their ear. We're not taking every kid to the OR that has a foreign body in their ear or nose. We're holding them in a papoose and doing it. And this brings up the next controversy of restraining children. So, so our current experience anyway is 51 cases, 100 years in sedation, and 9 cases or 18 years in the office where we just swaddled them, put local, and put the tube in. And all have been successful. So we've gone from the sedation unit as our first step that's now FDA approved. The FDA approved us doing PE tubes in a sedation unit, which is the whole idea of doing kids without general was kind of a shock, and this is where we were up at the FDA having arguments. And I think because of their black box warning, et cetera, they went ahead and approved it. And now we have an IRB study where we're starting to move to the office and do PE tubes without any general. And it's working quite well in kids under 2. But again, it's early, it's way early. So, and there was another company that was working on this, but they've had issues with the FDA getting approved, so they're not approved yet. They're having trouble with their anesthetic techniques in getting approved. I just bring it up to mention that there are other people working on this. Now, there's my good friend again, Rich Rosenfeld, who has really been a leader in otitis media and the current guidelines. He's kind of our leader from ENT on the guidelines with the American Academy of Pediatrics. And he started just putting tubes in kids in the office and wrote about it. And that freaked out my colleagues at Children's, who, when they saw this, when we were going through the arguments of doing PE tubes in the office, they were like, you can't do it. We have this comfort promise in children. You can't dare to do that. I don't know how many of you guys are familiar with Stefan Frigstorff and pain, but obviously this is a new issue of, how do we handle kids and traumatic procedures in the office? And the people at Children's were so incensed what was going on, they actually wrote an editorial in our ENT journal, our major one, saying that Rosenfeld, they wanted me to sign on to this. And I'm like, I'm not signing on to that paper. It's totally against what I believe in. And that we're causing problems in kids, that there's a significant trauma to the kids. And they have a legitimate argument. I mean, that are we causing some undue permanent trauma psychologically to these kids? And they published this in my journal, and of which Rosenfeld, if you know Rich, he's a very prolific writer, and he wrote a really good response about shared decision making and parents having their say in this. And then you have to balance the whole issue of general anesthesia risks. We're getting this whole issue now of what's the lesser of the evils, holding a child, restraining them for a few minutes, or sending them to the OR and that risk. And I want to bring something else. Just because you give a child general anesthesia doesn't mean you're minimizing the trauma. I will tell you, all ENT doctors will tell you, we have a lot of kids who have their tonsils out who have terrible nightmares for months afterwards. Now, whether that's due to the pain of the tonsillectomy or the general anesthesia, and how many kids, again, a lot of kids, you have to fight them on induction. You have to hold them down and put a mask over them. And so that also is trauma, and people just assume, well, if we give them general anesthesia, they're not going to have trauma. I don't buy that argument yet. So that general anesthesia is totally risk of psychological trauma from restraint. And then is the cost issue, that should be a factor in this. Should we get tubes out of the OR and bring them to the office? So, and I'll just point out again, when we do tubes in older kids, again, they're cooperative. What we're applying to children that are 1 or 2 is the same way we deal with older children. Obviously, the restraint's the issue, and is restraint worth the risk of the issues of general anesthesia? And again, we're not alone in this. Urologists do certain office procedures under local for adhesions. They're pretty happy with it, and they don't think, again, there's this question of psychological trauma of the child. versus what might be safer in terms of avoiding general anesthesia and also lowering costs. Obviously, from a theoretical perspective, we should be optimizing and minimizing stress and pain for children undergoing procedures. But does that mean every procedure an otologist does goes to the OR? I got to tell you, if you've ever seen us pull out foreign bodies from the ear and nose, and the ER docs do this, it's pretty traumatic, you know. But we do it. We don't take every foreign body in the ear and nose to the OR under general. I think that would be ridiculous. But you tell someone like Friedrichsdorf, we're doing it, and they go berserk because they're concerned about the psychological trauma we're creating. And I don't know what the right answer is. I mean, I think we all have to use our own moral compass on this issue. What I do, and again, this is nursing and talking about procedures in kids. I do want to say one thing though. PE2 placement is the only surgical procedure where the risks of anesthesia are greater than the actual procedure to the patient. This is about the only surgical procedure where the general anesthesia is more of a risk than the actual procedure to the patient. So the toughest part of being a physician is us counseling our parents on how to handle this situation. The other issue I'm going to briefly bring up, because I'm in the middle of a chat with Rosenfeld and others, is if we can do tubes really quickly in the office and effectively, do we need to go through 20 courses of antibiotics? Should we be doing tubes earlier? If I can put a tube in that has no risk of ligament perforation, that takes 10 minutes in the office, and we're not going to the OR, would that be a better technique than waiting for 10 courses of antibiotics? Would we help society and our resistance issue by going to quicker tubes if we can do them in the office? And that's how I'm going to end it. So I'm open for questions. Any anesthesiologist wants to throw darts at me, I'm here. I don't know if there are any. Yeah, Joe. Oh, thanks.
Right, I guess this gets to your last point. Frank, thank you. It was a great talk and fun. I think this gets to your a question about your last point about, prophylactic placement of PE tubes in order to avoid multiple courses of antibiotics. You know, it's been a long time since I saw a lot of kids in clinic, but there's always the PE tube in there piled up with cerumen and other mess. What's the functional length of time for a PE tube? How long does it actually really work?
Well, that's another great question. I always warn parents before surgery, you know, there are a lot of risks to PE tubes. There's perforation risks that we quote probably around 4 or 5%, so it leaves a hole in the eardrum. We got to fix it with another operation. And run this. It should last about a year. Sometimes they only last a week. Sometimes they last 3 years. And we run into this dilemma if it's in there 3 years. A lot of ENT docs after 2 years will take them to the OR again to pull it out, which I think is a little ridiculous. So there's extreme variability on length of PE tubes and how long they last. Most of us tell parents a year. It buys you a year of time. You're waiting for better immune system development and eustachian tube function to improve over time. So it's buying you time from infection for a year and damage to the middle ear. That's kind of our purpose of it.
I was hoping you could comment a little bit more on how these tubes that you're putting in the office are different. I've had a few of my patients who you've put them in, and do you know enough yet about, do they fall out sooner or later? What you said the risk of perforation is lower, and I was hoping you could elaborate on that a little bit.
So again, we're in our infancy. This, like all medical products, it needs to be improved. I think honestly a real problem we're having is the tubes coming out too easily or plugging too easy with the ones we're putting in the office. We think actually most of those problems are with nitrous, because nitrous may push them out earlier. So ear surgeons will tell you they don't like nitrous oxide when they're doing eardrum repair because it's going to blow the graft. And that may be part of our problem. Is the office ones seem to be actually lasting longer than the ones under nitrous. So we looked at this issue because we know they're coming out sooner because they're lighter. There's been no perforations with them. But when you look at our group of kids that have had sedation PE tubes and nitrous office PE tubes, the amount of kids that need a second PE tube is the same. It's about 30%. So even though they may be lasting 6 months or 9 months as opposed to a year and a half, the rate that needs a second set's the same. So the next question we're all asking is really 6 months a good enough time? There was a period where we had this thing called a laser meningotomy, where you would do an office laser cut, and that was all the rage, and you had to buy this $5 million laser for your office. And the problem is that never worked because the laser meningotomy only lasted about 2-3 weeks and it closed. So it wasn't long enough. But 6 months may be long enough, and I think a lot of us think so. So, I mean, it's a good question. So it is an issue we're working on, or it's being worked on. Yeah.
You're after me there, pal.
Oh, sorry.
That's okay. Thank you,
sorry,
Frank.
I just bumping people. So, well, I don't want to talk to this guy anyway. So anyway.
Well, that's because we've known each other for 25 years.
Yeah, exactly. Yeah, I know.
I'm not afraid to lock horns with you a little bit. So, thank you for bringing up this really important topic. And I would really direct people to, when we're talking about neurotoxicity and anesthetic drugs and sedative drugs, of which all have been implicated to some degree other than dexmedetomidine, I think you should look at the Smart Tots publications. Dean Andropoulos's very thoughtful editorial in the New England Journal. He is an anesthesiologist, and it's really not about them versus us. It's about what's best for kids. And best exposure to general anesthetics is good. But my question to you is, even so, nitrous oxide has also been implicated, as are the drugs that we use in the emergency department. I don't talk to parents about neurotoxicity. And are you talking to them about it with your nitrous?
Yeah, so first of all, I agree 100%. Read the Smart Tots stuff. That's the public line. I agree with it 100%. Second, though, is that you're wrong about nitrous oxide. And these are the arguments we had. This is what I get all the time. These are the arguments we get. There's a reason why the FDA didn't include it on its list. So if you look at the actual list that's black boxed by the FDA, nitrous oxide is not on it. And trust me, there was a lot of discussion, because I was part of that discussion, on including nitrous oxide on that list. We got attacked at the FDA with nitrous oxide for this very issue. And the reason is, and we've actually written a white paper on it, the FDA has seen, you really go through the research, nitrous oxide is a huge misconception given by a lot of people because it's of the same family. But nitrous oxide is not metabolized by the cells. It does not cause the same type of neuroapoptosis. It is not on that list for a reason, and that is, it's the same argument why it's okay to give for delivery. There's no body of evidence to show nitrous oxide is causing that problem. So right now, fentanyl, dexmedetomidine, nitrous oxide, are probably safe as far as we know in 2018 that I can say based on the scientific literature. So, but I agree 100%. You got to read the Smart Tots stuff. That's really the public line to go through. And I do. I'm probably one of the few surgeons who have this discussion. I avoid surgeries like branchial clefts and stuff that aren't infected. I tell parents to wait till 3. They have a stupid preauricular, stalk. I'm like, just come back to me when you're 3. I actually practice that because I think I believe in it. There's no reason to do elective surgery in kids under 3. But most surgeons aren't that way right now. Yeah, thanks for the question. They're great, Mark. Thanks. Yeah.
So my question is, if you can do this in the office, does that mean down the line this will be done by the pediatrician or the family physician rather than an ENT?
That is a great question. I forgot to bring a point. First of all, until the lawyers disappear in the United States, that'll never happen. This goes back to even pediatricians used to do myringotomies in the office when a kid was miserable. But the fear of medical legal consequences of hitting an obstacle, it'll never happen. However, you bring up a really super important point to this. There's a huge problem in underdeveloped countries in otitis media. It's becoming one of the major issues in the underdeveloped world, or that has no access to medical care. Could we train a general doc in Africa to do this? Of course. And the answer is yes. That's the beauty of this, is that we can get tubes out to the rest of the world. You don't have to go to an OR. They don't have to get general anesthesia. That's really the beauty of however you design a way to do office tubes, is to help the rest of the world with otitis media, where it's still one of the hearing loss is still one of the top issues by WHO. I think it's number 3, 4 by WHO as a problem right now, because they're surviving the other things that used to kill children because of vaccinations. Now they're dealing with what we're dealing with, problems with otitis media. So yeah, it's a huge thing. I forgot to bring that up. It's a great comment. So. Yeah, he wants to respond to my comment. So
there's too many other things to respond to. So the point about restraining children. We do not have papoose boards in the emergency department. And I think that it's very important for people realize there's a difference between using non-pharmacologic techniques, comfort care, all the things that are done in pediatric-specific places that I imagine you're doing as well, and then doing some swaddling, and then you do a procedure. Maybe you use minimal sedation like nitrous oxide, as opposed to taking the kicking and screaming child, tying him up in the papoose board, and then doing something painful without any analgesia. So, papoose boards are bad if they're used in that way. But doing minor restraint, like you describe, in the right way, I think is fine.
Yes and no. You're in a well-funded ER with child life and scribes. I don't have a scribe. I don't have child life in clinic. I have none of those advantages you have in the ER. So in reality, is that, I'm lucky if I have a medical assistant helping me to swaddle the child. So we don't have any of these advantages that most ERs have. We don't have child life in our clinic. We don't have any of these advantages. So we're stuck right now in 2018 to swaddle/papoose. I agree with you. I don't like it either. I'd like to find a way around it. And an ER is set up for procedures. That's what they do all day long. An ENT office is not. I mean, we do procedures, but we do, how many laryngoscopies do we do in the office? We do tons. Palm just holds the kid. I mean, that's where we are 2018. Could it be better? Of course it could. I don't know what certainly we're using the phones now and stuff to help the kids while we're doing it, and the kids are watching their phone, but we don't have a lot of the advantages that you have in the emergency room, I guess I'm going to say.
So I would push back on that and say that anyone can take the minutes that it's required to comfort the child, make sure, you're doing stuff with the parents right there with them. That's a huge part of it. And I would say that you're not far from being able to do it without them screaming and kicking. And I imagine most of them don't. But it's really about taking that amount of time. Yeah, we have child life, but not 24/7. And I think that there's lots of things that can be done to smooth this over, and I'm sure you're doing some of them and could probably...
Well, Dr. Neglia said he'll get you 24/7 child life now. He'll put that on the new budget. So
we don't need 24/7 because our staff are really committed to doing this.
Right. No, I agree with you. I agree with those comments totally. Right. It's something that us as surgeons, but again, most ENTs aren't peds. Most ENTs that are doing P tubes aren't pediatric trained. And they don't care about those issues like I care about them. I agree with you 100%. It is something we need to work on as a overall. And we got to come up with better ways in the office of dealing procedures. Because we're basically, all our procedures, foreign bodies, nasopharyngoscopy, we're just holding the kid. And there's got to be better. I agree with you 100%. So, yeah. Okay, thanks everybody. Thank you. Okay.
You have been disconnected from the meeting.